Today, we're going to have a little bit of a think about acute kidney injury. And at the end of the session, we really just want to think about what are the main causes that lead to acute kidney injury, and then some of the processes that are occurring throughout that injury to the kidney itself. So what's the pathophysiology going on? So what's going wrong with the physiology itself because of the injury to the tissue? So what about acute kidney injury? Well, thinking about how many people it affects in the UK, more specifically England, because that's where the figures are easiest for us to see, it affects about 600,000 people in England every year, predominantly in older adults. About 20% of people, of those who have it, die within 30 days, and mortality exceeds 30% in those who've hit stage 3 disease, which we'll talk about a little bit later. About 1 in 10 of those patients with severe AKI or acute kidney injury will require dialysis. And there are lots of risk factors for that. For example, the age that you are obviously predisposes you or makes it more likely, pre-existing illnesses that may go on to have an effect on kidney function, for example, chronic kidney disease and heart disease. And some of the common causes that we're going to think about later on are dehydration, so where you have a reduced blood volume, which means you have reduced delivery of blood to the kidneys themselves. Sepsis, so for example, in bacterial infections, that's affecting the blood, where you get widespread vasodilation. So that again leads to a drop in blood pressure. You can have it through heart failure or shock. You have nephrotoxic drugs, obviously, that may be affecting the kidneys themselves. And then finally, we'll have a little bit of a think about urinary tract obstructions, which can also go on to lead to acute kidney injury. So there are lots of potential causes in there. So what's actually happening in acute kidney injury itself? Well, you've got your kidneys, they're functioning nicely, but you get a rapid loss of kidney function. And that means, because the kidney is no longer filtering the blood, getting rid of waste, you get a retention in those waste products. You get a retention in electrolytes and fluid as well. So there are lots of potential things that are happening. An AKI is a syndrome rather than a single disease, because there are many different conditions that can cause a rapid decline in kidney function. Where we've already talked about some of these particular causes like dehydration and sepsis. So whatever the original cause is, you get a decrease in the renal perfusion, or you get kidney injury. One or two of those processes are occurring. That leads to a decrease in GFR. If your kidneys aren't getting the correct perfusion and they aren't able to filter the blood properly, the amount of filtrate you make decreases. So you get a drop in your GFR. That drop in GFR means, as I've already said, you get a retention of water, you get a retention of electrolytes and waste products. And overall, what this leads to is an increase in your urea and creatinine. So remembering that those are markers of kidney function. And so they are very important markers of acute kidney injury, because AKI affects much more than just waste removal. It also disrupts fluid, electrolyte, acid-base balance. So lots of things are happening. It also leads to the retention of hyperkalemia, or the retention rather of potassium within the blood itself. And that's particularly important, again, because it can cause potentially life-threatening cardiac arrhythmias. And just thinking the mechanism behind it, you have a decrease in GFR, less potassium is filtered, therefore less potassium is removed out through your urine. You also have what's a metabolic acidosis. And specifically what's happening in this case is you're getting a reduced secretion of hydrogen ions, and that is what is contributing towards that. You also get less regeneration of bicarbonate, which is a very important buffer for kind of resolving or stopping an acidosis occurring in the first place. And finally, you get a retention of fluid, and that can potentially go on to lead to edema. Okay, but it's also important to note that AKI does not always cause a reduced urine output. Okay, some patients can continue to pass apparently normal amounts of urine. Consequently, AKI, so acute kidney injury, is often first recognized because of changes in blood test results rather than symptoms themselves. So this is really why monitoring trends in renal function tests is a key role in the lab for kind of monitoring and looking and seeing what's happening in acute kidney injury. So where there are things that are happening as well, there are a couple of other little things. You may get a dilutional hyponatremia. So that just means that if this is someone who's having that fluid retention, the amount of sodium in the blood apparently starts to occur, or the concentration of it starts to drop. And that's just because of that dilutional phase. So what about in the urine itself? Well, those are the things that we just talked about that are kind of happening in the blood, and in the tissues. But in the urine itself, well, urine output often falls. So that's oliguria. But remember, it doesn't always fall. Some patients may be anuric, and some may remain non-oliguric as well. So you get that whole variety. But in most patients, urine output does tend to fall. But in some patients, it doesn't. So there is a kind of a definition criteria for the acute kidney injury, and it's diagnosed really from changes in creatinine and or urine output. And really a very small change, or a relatively small change or rise in creatinine, can actually indicate significant kidney injury. So this staging that we're going to talk about reflects the severity, and it's based on the magnitude of that creatinine rise or that reduction in urine output. And it's really important that when you're looking at these two things, so serum creatinine and urine output, that patients don't actually need to satisfy both of those criteria. Either one may kind of establish that diagnosis. And I don't expect you or anyone else who's listening to this to really remember these values, because they're all going to be given to you if you work it, if you're a health professional, or even if you're doing a biomedical science degree, whatever it might be, you're going to be given reference ranges. You're not going to have to memorize things like this, or I would hope not, at least. So, but it's just to put it into perspective. So you can start to define AKI if there's an increase in serum creatinine by greater than or equal to 26 micromoles per liters within a 48-hour time period. The increase in serum creatinine goes to greater than 1.5 times its baseline. So you need to have a baseline or a regular, normal creatinine level for that patient. And that's known or presumed to have occurred within the prior 7 days. So there's another of those criteria for you. So an increase by 26 micromoles per liter within 48 hours, creatinine to go up 1.5 times above the baseline. And so therefore, like I said, fairly small changes in creatinine are really quite clinically significant. Now we're thinking about the urine volume. So this is, not everywhere is going to be measuring urine volume, but it's where you get a deep drop in less than 0.5 mils per kilogram per hour for 6 hours. Okay, so it's a very low volume. And so therefore, using these kind of numbers together, you can start to stage the AKI. So you can start to stage it into stages 1, 2, and 3. Obviously, stage 1 is the least bad, and stage 3 is the most bad. Okay, and these are just shown in this table for you for general reference. I'm not going to go through them with you. Also, one last little thing we'll just talk about here is that creatinine rise may lag behind the actual kidney injury. And that can be from anywhere between kind of 24 or 48 hours. So bearing in mind, you see this creatinine changes, and that might actually lag that injury itself. Okay. So what are the major causes of AKI? Well, AKI is traditionally divided into 3 broad categories based on where the problem actually originates in the first place. So firstly, you've got pre-renal AKI. And as it suggests, this occurs before the kidney and results from reduced blood flow to the kidneys. So you're getting a reduction in your blood flow coming to the kidneys through the renal arteries, therefore getting a reduction in GFR, and therefore leading to a reduction in filtration, and also to a reduction in the amount of nutrients being delivered to the kidney tissue, which therefore means the kidney starts to struggle and have to work anaerobically and not get enough energy. You also have intrinsic AKI or renal AKI, and that's where you're getting damage to structures within the kidney itself. And finally, you have post-renal AKI, where there's an obstruction of urine flow. So it's after the kidney, and that can be blockage of urine flow anywhere from the kidney down to the urethra itself. And the classification is really clinically useful because investigation and management differs between the 3 groups. And so now what we're going to do is we're going to look at each category in a little bit more detail. Okay, so we're going to be thinking about, oh yes, I forgot this was here. So I want you to actually have a little bit of a think about each of these. So On the left-hand side here, we can see your pre-renal, your renal, and your post-renal causes. I would just like you to have a little look at each of these causes and tell me which one do you think is pre-renal, which one is renal, and which ones are post-renal. So I just want you to have a little bit of a look and have a think about that. We'll start with severe diarrhea. What do you think that is? Hopefully you said pre-renal because of course you're losing fluid in that through diarrhea, which is obviously a pre-renal cause. It's nothing to do with anything happening afterwards or in the kidney itself. Acute tubular injury, well, hopefully that's nice and obvious. So you've got tubular injury of the kidneys within the nephrons, so it's a renal cause. Kidney stone, okay, so that is usually afterwards, after the kidney. So that might be in your ureters, for example. So that would be post-renal. Heart failure, again, heart isn't working very well. So the amount of blood, the cardiac output starts to drop. And so therefore that is a pre-renal cause. Renal artery stenosis. So again, that's in the pre-renal because it's the renal artery is delivering blood to the kidney itself. So it's before that kidney. Benign prostatic hyperplasia, so an enlarged prostate that squeezes down around the urethra, so that's the anatomy behind its location, so it's starting to kind of stop urine flow, sorry. So of course that is post-renal. You've got septic shock, so bacterial infection, for example, in the blood. So again, that is pre-renal, it's happening in the blood, altering the amount of blood going to the kidneys. Glomerulonephritis, even if you don't know what this disease is, you know from itis, it's inflammation and it's of the glomerulus. So it's obviously a renal cause. You've got NSAID use and potentially other drugs. Some drugs will be acting on the kidneys themselves and are nephrotoxic. So that is a renal cause. And then a bladder tumor. So a bladder tumor potentially blockaging or slowing down urine outflow. So again, that is post-renal, it's after the kidneys. So thinking about the most common cause, pre-renal AKI is the most common form. It's often reversible if it is treated early. And so this is where we're going to start now. We're going to look at each category in a little bit more detail, and we'll start with that pre-renal causes. So we've already had a little bit of a talk about this. So we already know, if we're looking at this right-hand side, the kidneys receive about 20 to 25% of cardiac output, so it's a huge amount. And there are lots of causes of reduced renal perfusion, so which is your pre-renal causes. So there might be a reduced circulating volume. So for example, blood loss. There might be reduced cardiac output, the heart can't pump as well, or there may be systemic vasodilation. So that means the blood pressure drops. All of these will reduce in a decrease in renal perfusion and therefore a decrease in your GFR, and therefore also decreased supply of nutrients to the kidneys itself. And like I said, pre-renal AKI is the commonest cause of AKI. So let's have a little bit of a think about these. What causes, so press pause now and then just have a think. What reduced circulating volume, cardiac output, systemic vasodilation, and renal blood supply causes can you think of? Bearing in mind, we just covered some of these. So reduced circulating volume. Hopefully be coming up with things like hemorrhage, so blood loss, diarrhea or vomiting, where you're losing lots of volume, and burns, in particular significant burns where you can lose a lot of volume. So reduced cardiac output, things like if you've had an MI or if you have heart failure. Systemic vasodilation, you might be thinking about anaphylactic shock or sepsis, or both of which cause systemic vasodilation and therefore drop in blood pressure and drop in blood flow to the kidneys. And reduced renal blood supply, so you may be thinking renal artery stenosis. Common cause of this being, of course, atherosclerosis. So the important thing about these causes of this is the kidney itself is initially normal. The problem is actually the inadequate blood flow reaching the kidney. So like I've said, the reduced perfusion lowers GFR, reduces filtration. And like I said, if recognized early and treated early, pre-renal AKI is often reversible, but if renal hypoperfusion, so low perfusion to the kidneys, persists, that's where you can start to go into tubular injury, leading to intrinsic or renal acute kidney injury. So let's have a little bit of a look at this in a little bit more detail, remembering that in the normal circumstances, the kidney is actually fine at the moment. So hypovolemia, reduced cardiac output, reduced effective circulating volume, those are the things we just talked about, all lead to a reduce or a reduction in renal perfusion, which leads to a reduction in the glomerular filtration rate. Now, if you start to drop your GFR, we've talked about the regulation of GFR in an earlier podcast, you get a compensatory response. So your renin-angiotensin-aldosterone system becomes activated. Antidiuretic hormone or vasopressin is released, and you get activation of the sympathetic nervous system. So the body is responding by activating these systems, and these mechanisms help to preserve circulating volume by retaining sodium and water. So the SNS, well, of course, that has systemic effects. So it has effects throughout the body. It leads to the tachycardia, so an increase in heart rate that you may detect, and peripheral vasoconstriction, both of which are helping to maintain blood pressure and perfusion. You get the renal effects. So you get salt and water conservation through the renin-angiotensin-aldosterone system and ADH. So that, of course, by retaining that sodium and water, leads to oliguria, so lower volumes of urine being produced. And of course, the urine becomes more concentrated with waste products. And you'd also, as you'd expect, get a low urine sodium concentration, which is what you would expect because you're reabsorbing sodium and water is following. And of course, following on from that, the biochemical consequences of that oliguria, so less urine being produced, arise in the waste products, part of the UNEs, so the kidney function test, an increase in urea and an increase in creatinine. So if you don't get that kind of that treatment effectively, then you can get progression from pre-renal to intrinsic AKI. So that persistent hypoperfusion leads to ischemic, so lack of blood supply, tubular disease or damage, and intrinsic acute kidney injury. And basically, the tubular cells that are doing all the work in the kidneys start to become deprived of oxygen and deprived of ATP, and that's what's leading to this whole process. So that persistent hypoperfusion, it becomes an ATP depletion because they're not getting the oxygen and they're not getting the nutrients that they need to generate energy to keep functioning and working. That leads to your acute tubular injury. That, of course, is causing intrinsic or renal acute kidney injury. And in itself, that also leads to a drop in GFR because, of course, the kidneys aren't working, the nephrons aren't working. The compensatory mechanisms carry on. They don't just stop. They continue to be activated, but that renal function now is continuing to decline. The damaged tubules can't retain sodium because they aren't working properly and water is effectively. So the urine sodium now starts to go up, and the urine is becoming more dilute because of water loss. Okay, so you're starting to see changes occurring in the urine volumes and concentrations as well. And all of that leads to an increase in creatinine and urea, just like in pre-renal, but also you get an increase in blood potassium, so hyperkalemia, and you go on to a metabolic acidosis as well. But what about intrinsic AKI? Well, we talked about acute tubular injury a second ago, and this is by far the most common cause of intrinsic AKI. AKI may develop following prolonged ischemia, as we just talked about, from untreated pre-renal AKI, or exposure to nephrotoxins, for example, such as the NSAIDs, non-steroidal anti-inflammatory drugs, or to myoglobin, which is an oxygen storage molecule found in skeletal muscle. So if you get a lot of skeletal muscle damage, myoglobin is released, becomes filtered, and that is toxic to the nephrons as well. But in intrinsic AKI, there is actually now structural damage to the tubules themselves rather than simply a reduction in blood flow. And so that ischemia, that lack of blood supply, and the toxins cause ATP depletion. That impairs normal tubular cell function. So you get impaired sodium reabsorption. So they also start to lose their ability to concentrate the urine. So you get, with that damage to the tubular cells, you get sloughing of the tubular cells. They just start to break off because of their death. And that can lead to tubular obstruction. And that tubular obstruction, of course, forms kind of what are called casts, and they obstruct those tubules, and it increases the pressure within the nephron and contributes to a further reduction in GFR because you've got obstructions within the kidneys, and that's that back pressure pushing up against the glomerulus itself, so reducing the amount of filtrate that you can form. And that helps to explain why you get an increase in creatinine and urea. So they keep going up despite the compensatory mechanisms that are being activated. Like we've already said, you get a decrease in urine concentrating ability because you've got tubular injury, you can't concentrate the urine, and so you get an increased urine in there as well. And that's actually a really useful kind of clue as to what's going on, is that urine sodium concentration. So a key thing here is, where is the sodium? So in pre-renal, if you look on the left side of that image, in pre-renal AKI, the tubules are still functioning. Okay, so sodium is retained and the urine sodium is low. In intrinsic AKI, the tubules are damaged and cannot reabsorb the sodium effectively, so more sodium is lost in the urine. Therefore, a key thing here, low urine sodium suggests pre-renal AKI, whereas high urine sodium suggests intrinsic AKI. So that's a little bit of a comparison, or a way of starting to distinguish from a clinical biochemistry perspective. So let's have a little bit of a review question for you. So I'd like you to press pause, read through this, and just try and answer the question. So a 72-year-old man presents to ED with a 5-day history of vomiting and diarrhea. Blood tests confirm AKI. Despite IV fluid replacement, his renal function continues to worsen and he develops acute tubular injury. So he's developed AKI, so renal AKI. So he's gone from pre-renal to intrinsic AKI. Which combination of urinary findings is most consistent with this progression from pre-renal AKI to intrinsic AKI? Is it A, B, C, D, or E? And we did do this just in the last slide. So hopefully you can kind of, if you don't know the answer, kind of have a think about it and work through it. Hopefully you put B. So urine sodium is high and urine concentration is low. So remember, in pre-renal AKI, functioning tubules conserve sodium and water, which means you have a low sodium, urine sodium, and concentrated urine. So that's what you would expect to see. So option A, in other words, is what you would expect to see if it was pre-renal. However, in intrinsic AKI, the damaged tubules cannot effectively reabsorb sodium or concentrate the urine, meaning that you get a high urine sodium and less concentrated urine, and that is option B. So you've got A is pre-renal, B is renal or intrinsic AKI. Okay, so the final bit that we'll do now is look at post-renal AKI pathophysiology. And this normally results from urinary tract obstruction affecting both kidneys or a single functioning kidney. So there are lots of causes. They include things like malignancies, they include things like kidney stones, and an enlarged prostate. So some of the examples that we've already talked about. And so what's actually happening in this case? Well, you're getting an obstruction, and that obstruction increases pressure upstream. So if we're looking down this image on the left-hand side, you might have an obstruction down here. It can be in the ureters, doesn't really matter where it is. So you can pass it all the way down. And because you've got an obstruction there, the fluid's got nowhere to go. So the fluid backs up, kind of backs up, and increases the pressure in the Bowman space, meaning there's greater pressure opposing filtration. So what that means is you get a drop in your GFR, and because you've got a drop in your GFR, and also there's nowhere for the filtrate to go, you get a drop in urine formation as well, leading to oliguria or anuria. And that obstruction, of course, is also, if it becomes persistent, starts to lead to tubular injury, and that tubular injury leads to secondary intrinsic AKI. So just like pre-renal AKI can lead to tubular injury, post-renal AKI can also lead to intrinsic AKI. And again, things that you might see, you're expecting to see an increase in urea, an increase in creatinine, and hyperkalemia if it's prolonged, again, because you drop that GFR, so the potassium begins to build up. So remembering the key thing here, post-renal AKI occurs because obstruction increases pressure within the urinary tract, reducing GFR and reducing urine formation, leading to that increase in urea, creatinine, and potassium as well. So what I'd like you to do now is just complete this little table. So thinking about the three causes of AKI, so we've got pre-renal, renal, and post-renal. Think about what's the mechanism, what happens to urine sodium, urine concentration, and the key causes. So press pause, have a little bit of a think about it. So this is quite a useful one for you to think about what's the summary difference between each one. Pre-renal, the mechanism is a drop in blood supply to the kidneys. What happens to the urine sodium? Tends to be low. Urine concentration tends to be high. The kidneys are working fine and are doing what they're meant to be doing, which is reabsorbing sodium and making a concentrated urine. Key causes, things like dehydration and sepsis. Intrinsic mechanism, we've got damage to the nephrons themselves. The nephrons now aren't working, so the urine sodium becomes high and the urine concentration becomes low because there's lots of water loss as well. The tubules aren't working. Key causes, ischemia and toxins, such as nephrotoxic drugs. Post-renal, so there's an obstruction somewhere. Sodium is variable, urine concentration also variable, and the key causes enlarged prostate and kidney stones, for example. So it's kind of a nice little summary table for you to think about there. So what are some of the consequences of AKI? Well, we talked about the retention of potassium, and it, of course, that retention of potassium has influences elsewhere, not just on the kidneys, but in other parts of the body. So the hyperkalemia can lead to cardiac arrhythmias and ECG changes. A common one being, as you can see there, a tall peak T wave. And if it becomes significantly high, can cause fatal cardiac arrhythmias. You've got retention of fluids, you've got fluid overload, and that can result in edema, and that can occur obviously in the pulmonary system as well, so leading to a reduction in exchange of oxygen and CO2. And then you get the retention of waste products and acids. So for example, a retention of hydrogen ions, lack of bicarbonate regeneration, leading to a metabolic acidosis, and uremia. So uremia is just an increase in waste products. And so that can lead to confusion, seizures, and coma, just because the metabolic acidosis and uremia can affect the nervous system, leading to those complications.